Hello, I'm May Smith from the editorial board of Open Anesthesia. Today we have the pleasure of interviewing Dr. Jonathan Wanderer as part of the podcast series co-sponsored by Open Anesthesia and Anesthesia and Analgesia. Dr. Wanderer's article was chosen as the article of the month, and it's entitled Trends in the Prevalence of Intraoperative Adverse Events at Two Academic Hospitals After Implementation of a Mandatory Reporting System. Dr. Wanderer is Associate Professor of Anesthesiology in the Department of Anesthesiology and Biomedical Informatics and Director of Vanderbilt's Anesthesiology Perioperative Informatics Research Division, affectionately known as VAPOR. He's from the Vanderbilt University Medical Center in Nashville, Tennessee. John, thanks for joining us.
Thanks so much for having me.
So for starters, I wonder if you can summarize for our listeners what you were hoping to find with this project and how your study was organized at the two institutions.
Sure. So this really began as a project from Thomas Jefferson University Hospital, and they were looking to have some quality improvement initiatives focused at the most prevalent adverse events in the intraoperative space. And so they did a retrospective analysis looking at rates of adverse events since they instituted a mandatory system which requires you to select if you had an event or not at the end of each anesthetic case. And what they found, while expecting to see an increase in adverse events reported after implementing the system, was actually a decrease over time, which wasn't expected. And looking into the data a bit more closely, they split out all of their events into preventable and unpreventable adverse events. And they found that while the rate of unpreventable adverse events was constant over time, they had a decrease in preventable adverse events. And they reached out to us at Vanderbilt, since we've had a similar system in place for quite some time, to see if they could replicate the findings. And although we didn't have the ability to split the events into preventable and unpreventable, we were able to look at the event rates over time and saw that they in fact declined, suggesting that there might be some association between putting in place such a system and the overall rate of intraoperative adverse events.
Well, so that's really interesting and exciting that your results were the opposite of what you expected and actually in a favorable direction. What were the findings that made you think that there was indeed a decrease in preventable adverse events as opposed to just a decrease in reporting of them?
So part of what made us think that that might be the case is we have a mix of provider types at both institutions. We have a lot of student nurse anesthetists as well as residents here at Vanderbilt, residents at Thomas Jefferson, and we saw the declines over time. And of course, that suggested it wasn't related to new groups of people coming in and might be related more towards organizational change or something that fundamentally shifted in our safety culture. Whereas if we had a decrease in reporting, you might expect that to be and effectively isolated to the trainees within the group, and you wouldn't have that sort of learn decrease once you got used to using the system.
So at one of the institutions you said in the paper that there was a decrease in preventable adverse events, but that this decrease sort of plateaued after a while. And I wonder if this surprised you and if you have any theories about why the adverse events didn't continue to decrease.
That's a great question, and I think ultimately there probably will be preventable adverse events that occur because we're human beings working in a complex system, and I think we're probably never going to be able to stop all of the preventable harm. But I think probably what we're looking at is plateau in terms of the impact on the safety culture, and hopefully this isn't as low as we could drop the rate, but it seemed to be as low as the association that we saw with our system being implemented occurred.
Okay, so you did say, though, that the QA reports that were generated were officially reviewed by the QA officers. And so I wonder, as part of that normal QA process, if there were any more subtle quality improvement changes or education via M&M discussions that might have also contributed to improved practices and outcomes.
Absolutely, and I think that's really, what drives the whole culture of safety. And we've had a few specific instances of specific events in a short period of time that really caught our attention. So to name a couple of examples, we had a rash of corneal abrasions that were reported through our adverse event reporting system that led to an M&M specific to management, diagnosis, and prevention of those injuries. And then separately, some related M&M material that recovered for defibrillators that did and did not have pacing capacity. which are scattered throughout our environment. So there are some, specific actionable educational interventions that came out of this reporting system. And I think what we see on the whole is the cumulative impact of reviewing these events on a monthly basis and quarterly basis with our surgeons, as we do here at Vanderbilt, that has been helpful in sort of shifting overall safety in the OR.
That's interesting. So that's really exciting. I think that one of the major contributors is an improvement in the safety culture. We've certainly heard in many institutions how difficult culture is to change. And so I wonder if you have other ways of measuring this shift in safety culture that could support your hypothesis.
I think we could probably get to that perhaps by surveys and trying to assess for our providers' willingness to report events and occurrences, as well as looking at the kinds of reports that are filed and sort of the manner in which they're filed. Sometimes these systems can be used potentially in a punitive manner or as a way of, quote unquote, writing someone up. And so I think, although we haven't done this, we could potentially do an environmental survey that would help support our conclusions, or potentially look at the change in type of language and tone that's used in the event reports that are filed, moving from things with potentially colored tone to more objective, state the facts kind of an approach.
So finally, I'm thinking that many people believe that clinical outcomes are not the result of the efforts of a single individual, but rather the coordinated efforts of an interdisciplinary or interprofessional team. I know you just mentioned that the surgeons do review some of the cases with you, but I wonder, can you think of any ways that implementing this hard stop electronic reporting mechanism for anesthesia providers may have affected the work of other personnel in the OR also?
Absolutely. So I think when we do have these events, we want to make sure that they're reported, but we also don't want to have unnecessary work that's created from that. And so as part of completing the event tab, if let's say there was an IV infiltration that was noted, we might have a communication with the nursing staff and say that we're going to put the event in our events tab, and that would obviate the need for the nurse to separately report that complication through their system, because the way that we have our systems built, it really only is in the workflow of the anesthesia and the packing nurse providers and not threat everybody in the hospital.
So I think what I'm hearing is that even though the system is one person talking to an electronic system, it's actually facilitating real live communication between care providers, which obviously is a wonderful outcome.
Absolutely, and also facilitated communication within the team. And I've had a number of cases where we had an event, and then when reviewing the chart before closing it, looked to the events tab to see if it was included in the report, and sometimes it's not, which is a great opportunity to have a conversation around the importance of event reporting, which we'll have with the person who I'm working with on the case, so that we can have better capture moving forward.
Great. Well, thank you, John. Really appreciate hearing the researcher's perspective on a really interesting paper.
Thanks so much for having me.